So this is an example of the frontal plane control that we discussed. It was discussed during the basic injury mechanisms, but we want to review it here because we're going to talk about it relative to osteoarthritis and joint loading. And so let's focus on the left-hand example first. And in this case, the external load is a varus load or an adduction moment. And so the internal response that's needed is an abduction moment. And this is normally what we get when we're walking. Okay, so normally there's an external adduction moment, and our body has to respond by generating an abduction moment. And so we can see here what this is focusing on is, in that situation, the axis of rotation shifts to the medial and condyle of the femur and the tibia, and so there's a lot of contact stress on the medial side of the joint, but not the lateral, because that tends to gap unless the muscles close it. And we can see here how in this example it's emphasizing the fact that the quadricep muscle or the patella tendon can act to close the gap on the lateral side of the joint, because when the axis is medial, it has a moment arm toward opposing or resisting that external adduction moment. So let's focus now on the right, and we have exactly the opposite situation. So we have, in this case, an external valgus or abduction moment, and so now the axis is shifted to the lateral side of the joint, and the gapping is occurring on the medial. And so in this case, the quadriceps, again, because its moment arm is central, is toward adduction in this case, and can close the gap on the medial side of the joint. And so this is why the relevance of quad control in terms of balancing the frontal plane moment. But that's only one focus of the cause of the moment, and excessive moments, especially in the case of knee OA. So what we want to do now is focus our understanding of how this biomechanics integrates with problems of knee OA in patients. So let's focus our attention here up on the diagram in B here and see what's happening. So we have the normal situation here, where we see the ground reaction force represented in this dotted line up toward the center of mass of the body, and we have a knee abduction moment. And so our body should be able to handle this fairly well because we've done that throughout our lives. Now, as people have problems with knee OA, something that happens, they stop using the limb and they get weakness in their hip abductors. And so if they also are allowing their pelvis to drop, we can see the other thing that's going to happen is that dropping the pelvis will shift the ground reaction force, so it follows the center of mass, which is now farther away from the knee joint center, and so the knee abduction moment increases, and so there's a bigger demand to try to close that gap on the lateral side while they're walking. So this is a study that was performed in 2010 to evaluate whether hip abduction exercises to balance out the pelvis and restore a normal knee abduction moment might in fact lessen pain, because there's less joint contact forces, meaning i.e. there's less muscle contractions that's needed to stabilize the knee, and their overall load on the medial side would be decreased because the moment's less. And essentially what the bottom line of these results is that there was a reduced symptoms and improved strength with no differences in the knee abduction moment. So the explanation for the improvements had more to do with just general fitness, but they weren't able to decrease the knee abduction moment in this particular study. And here's another study, similar goals, where they had patients with knee OA versus controls, and they had similar exercises. You can see them here. And they also evaluated pain and the knee abduction moment. And we can see here they tested whether isokinetic hip abductor muscle strength improved, and there was a difference, so that was better than baseline. And then they also looked at the changes in the moment. We can see here statistically there were no differences. So, um, and then in terms of activity levels, this is a test of activity levels marginally close to significant. And then in terms of function, we can see here that there was some improvement in function in the final testing, so it was better. But here's their comparisons in terms of pre and post training, in terms of the loading at the knee abduction moment as they walked. So the y-axis here is how high the knee abduction moment is in terms of their walking, and we can see it's still higher in the OA group, and the post training there was really no effect in either group. Now here's another example of training to try to decrease the knee abduction moment in patients with OA. And in this particular example, they're focusing on weight loss programs. So there's no physical training except for that's focused on aerobic training. And so this is in 2011. And we can see this is the knee abduction moment here, and then here's the knee extensor moment. Okay, and we can see here that the decreased weight actually does help reduce the knee abduction moment. So the post is in blue. So the pre weight loss programs here, and so essentially we can assume that there's some benefit in terms of joint loading from an intensive weight loss program. So in summary, the knee abduction moment's relevant and increased in people with knee OA. It's thought to be associated with the Trendelenburg type of gait problem with the glute medius at the hip. And however, there's mixed results in terms of pain reduction from a program directed at the hip, and neither program, except for weight loss, has shown that there's a reduction in the knee abduction moment associated with OA.